Today my topic is applied shoulder anatomy, the diagnostic algorithms and the evidence-based management for shoulder pain. I bring greetings from AIMS Gorakhpur, and my learning objectives I have divided the same topic into three parts, basically the clinical relevant anatomy, the use of diagnostic algorithms, and then integrate them into evidence-based therapy, and that's how we deliver precise patient-specific pain management. So why this topic is important? Because pain of shoulder is actually a pain for us. And why do I say so? Because of high prevalence, around 70%, third most common musculoskeletal condition. It's multiple overlapping pathologies leading to misdiagnosis and delayed recovery. Then you have management varies consultant, means you have the physiotherapist, you have the orthopedician, you have the pain physician, and likewise. So next is the multiple physical examination tests. You have more than 100 tests and they are often misleading with low specificity and sensitivity. Then you have unnecessary imaging. You have to diagnose the red flags, and that's why you need the evidence-based pathways. So first part, applied anatomy. The most important thing you have to understand is pain is inevitable because of the minimal stability. So that's why shoulder pain is so important. And to begin with, you have to divide it into the functional parts. So first is the shoulder joint, which is the glenohumeral joint. Again, as I told, only 25 to 30% of the humeral head is in contact, leading to inevitable pain. Then you have the soft tissues which cover up for this mobility. So they become the actual pain source. And actually the glenohumeral osteoarthritis is less common. But if it happens, there will be cartilage and subchondral bone degeneration with joint space narrowing. Coming to the acromioclavicular joint, it's a small joint, but it's very common and prone to degeneration. It's richly innervated, so there's disproportionate pain. And if you want to localize it, it's always there on the superior part of the shoulder, and it will be AC joint pain until otherwise. Coming to the rotator cuff, as we all know, there are the 4 rotator cuff muscles as shown in the diagram. So what is the relevance here? They actually are important for centralization and prevent superior migration and also maintain subacromial clearance. So the supraspinatus is the most common pain source, followed by the other muscles which are the infraspinatus for the posterior pain and subscapularis for the anterior shoulder pain. One more important thing I want to highlight is if there is partial tear, there will be more pain, and if there is full thickness tear, there will be more of weakness. Coming to the next part, which is the long head of bicipital tendon. This is important. Why? Because it's a part of the attached to the supraglenoid tubercle, so it's part of the glenohumeral pain link. Then it traverses to the rotator interval. Importance we'll discuss later. It's richly innervated and a potential pain generator, and it causes shoulder pain, and it often mimics rotator cuff pathology, and also involved in the slap and acromioclavicular related pathology. So when you think of shoulder pain anteriorly and there's normal RC, then you suspect long head of biceps tendon. Coming to the rotator cuff interval, this is basically a triangular space between the supraspinatus, subscapularis, coracoid process, and it contains 3 important structures: the long head of biceps, coracohumeral ligament, and the superior glenohumeral ligament. It's critical for the anterior stability, and if it fibroses, then it's the basically most important part in adhesive capsulitis. And it's also the most choiced area for where you give hydrodilatation. Coming to the coracohumeral arch, most of the pain is associated because of the impingement, which was an earlier definition. Now it's combined and called the pain syndrome, means subacromial pain syndrome. So basically it covers the rotator cuff interval, the long head of biceps tendon, and the subacromial space. It also is altering our needle path and a key ultrasound landmark. Now coming to the most important part for adhesive capsulitis, which is the coracohumeral ligament. So it basically envelops the long head of biceps tendon. It's the most important thing related to external rotation. It thickens, and that leads to the decreased external rotation and anterior pain, and it's a target for the capsular release. In MRI, if you have more than 3 millimeter of coracohumeral ligament, that means it's a pathognomic for frozen shoulder. And it's basically a diagnosis until proven otherwise. The joint capsule is again important. Inferior capsule along with the axillary recess is the most important contributor. It's a target for the hydrodilatation and again a common source for non-traumatic shoulder pain. Then you have the shoulder bursa. We have two bursa. The subacromial bursa is very important and is again a pain amplifier. And it's the site for giving your drugs. Coming to the neural targets, you have the axillary nerve, the suprascapular nerve, and the lateral pectoral nerve. They are targets for the radiofrequency ablation. Second part of algorithm is basically the algorithmic approach. So you have 5 important features based on which you can go for the algorithm. One is to identify the red flags. You have the localization of pain to exclude referred pain. Then you have the pain, whether it is on active range of motion or on passive range of motion. Then you have the strength testing or the provocation maneuvers or the tests. And finally, you have the intervention. So how to go about it? Start with the red flags. If it's a yes, that means serious pathology. Go for the MRI labs and you may have to refer to a specialist. But if it's a no, that means it could be a poorly localized with normal range of motion, unrelated to movement, then definitely it's not shoulder pain, so it could be a referred pain. But if it's in the shoulder area, then you take whether it is in affecting the active range of motion. If it's a no, go back to the referred pain. If it's a yes, then take the passive range of motion. If that's also restricted, then if it's a yes, then you have to check whether the pattern of stiffness is global or not. And if not, then you go to the 6th step, which is the next slide. And if the pattern is global, then think of adhesive capsulitis. And if it's a no and corroborating with the X-ray, then it's a glenohumeral arthritis. Next, the 6th step is the pain reproduced with resistant movements. If it's a yes, then you have to take the tests, means the rotator cuff test. You can take any or multiple is better. But if the pain is not resisted, then you go to the painful arch, which is the 9th step. If it's the rotator cuff test is positive, then you have the rotator cuff disorder and it could be a tendinopathy or a tear. But if the rotator cuff test is not positive, then you have, I told the confounding could be the long head of biceps tendon. So you go for a speed test or the Yergason's positive. If it's that, then you are arriving at the biceps tendinopathy. But if it's a no, then you have to go for the painful arc syndrome. And you see whether it is mid-range or end of range. If it's mid-range, then you have the impingement syndrome. If it's a no, then you go to the localized area, which is the acromioclavicular joint. And you arrive at the acromioclavicular joint pathology. But if it's also a no, then you are left with the instability or laxicity of the glenohumeral joint. And if none of these are correct, then you land up with the functional or myofascial pain, or you have one more component, which is basically the scapular rhythm, and it could be a dysfunction of that. The important finding will be a MRI is normal. Once you have done, these are the 3 sources which I have chosen and I have made an algorithm of my own. Then you coming to the tests, as I told, there are so many tests. Maximum is for the rotator cuff tests. So basically they guide, but they are not accurate. So you have to always interpret with the clinical context and you combine them. Next is the imaging. So you have 3 things. One is the X-ray, one is the ultrasound, and the other is the MRI. This is the shoulder X-ray. Obviously for osteoarthritis, you will have a joint space narrowing. You can see the calcific tendinitis. And in ultrasound, you can find 4 pathologies like the rotator cuff tears, the tendinosis, where it thickens, or the calcific tendinopathy, or the bursitis. Details I won't be sharing here because of lack of time. And it matches the MRI in case of tears. And you can do a dynamic assessment and go ahead with the intervention always. Then you have the MRI, it is the gold standard. And MRA means you inject a dye in cases of labral tears or the axillary recess, which you can identify. Coming to the last part, which is evidence based. So I have divided into the common ones, means if it's a rotator cuff, the most important and strongest evidence is for the patient education, physiotherapy, where you have the scapular stabilization and rotator cuff strengthening, which is basically a type of AAROM, means assisted active range of motion exercises, followed by loading and followed by rehabilitation, where the patient is repeatedly and in a structured pattern comes to functional activity. Then you have the NSAIDs, which is only for the participation in the rehab and the EVAGE guided subacromial subdeltoid bursa injections. In partial thickness tear, you again continue with the structured rehabilitation, consider the injectates. But in full thickness, you still give an initial conservative trial, but you have to go for surgery, especially in the active patient like the sports persons, or in persistent pain, which is not being relieved by rehabilitation. These are my evidences. All are of around 2020 and till 2025. So the conclusions are, they are strongly recommended. Then again, comparison of the non-surgical and surgical, it was found that you must give a non-surgical trial. What are the injectates? You begin with corticosteroids, which is most common, and you can give it subacromial as well as intra-articular, but it's short term. This is again strongly evidence that it's short term and it doesn't decrease, means change the course of the disease. It can be repeated, but maximum 3 times. The evidences are shown here. Then you have the hyaluronic acid injections. Again, it improves pain and it has been found to be better than physiotherapy alone. Ultrasound is important, and in all the procedures, ultrasound has improved the accuracy and level of evidence is also moderate. Then you come to the third one, which is the platelet-rich plasma. It does improve pain, especially in the mid-range, means more than 12 weeks and less than 6 months. So, but the evidence is variable. And finally, prolotherapy, it is not recommended. These are the evidences. Additional or standalone, always additional is better than standalone. This is a systemic trial. Then you have the platelet-rich and hyaluronic acid, two separate. One is from the shoulder and elbow. And what do they say? See, this is variable. The outcomes are variable. It's corticosteroids have been better than PRP. Sometimes the exercise was equivalent to PRP. So there are so many examples, and it's variable. Similarly, in rotator cuffs, there is a meta-analysis. Again, the results are variable. Coming to adhesive capsulitis, the physical therapy again is most important. Here, you have the pendulum or the Codman's exercises, which is very important, especially in the initial phase when you have given an injection. Then NSAIDs and paracetamol, oral contraceptives. Image guided, again, you can give the intra-articular corticosteroids, sodium hyaluronate, and the most important is the hydrodilatation, and the technique I told is rotator cuff interval is preferred over the posterior glenohumeral recess. Then you have the suprascapular nerve block. Then you have the biologic and regenerative therapies, which is promising, but not much evidence till now. And in refractory cases, you can do manipulation under anesthesia. These are my references for corticosteroid injection, for hyaluronate, and multiple corticosteroid injection, 3 times maximum. This is the research on hydrodilatation, and the second one is basically comparing the 2 approaches. This is the PRP in adhesive capsulitis. Again, coming to the last, glenohumeral osteoarthritis. The non-operative management remains the same, followed by NSAIDs, followed by intra-articular. Here the corticosteroids inconclusive. It's not recommended. And again, about hyaluronic acid, although response has been modest, but the American Academy of Orthopedic Surgeons do not recommend it routinely. Then you have the suprascapular nerve block and PRP, which is again limited to just 2 trials. Then the other orthobiologics, they are limited and inconclusive. These are my evidences, and just concluding. And what are the non-recommended? There is a long list. Standalone ergonomic changes, therapeutic ultrasound, TENS, electromagnetic, galvanic, taping, slings, manual therapy, opioids, muscle relaxants, anticonvulsants, SRI, glucosamine,
capsaicin, these are all non-recommended or insufficient evidence is there. And you can find this in this article. Everything is mentioned here. Role of radio frequency, basically it's all three, pulsed, thermal and cooled, all are, there is limited evidence though. And the targets are three, which is suprascapular, axillary, and the basically the lateral pectoral. These are my references. So the keynote take home message is: anatomy explains the symptoms, diagnostic algorithms create clarity, know the red flags, stratify severity, always individualize care. No single test is perfect, combine them. The patterns are better than isolated findings. Combine the history, examination function. Treat the patient, not the MRI. Conservative therapy will always remain first line. Exercise and rehabilitation is central. Interventions facilitate but not definitive, and escalate only to surgery if needed. Thank you very much.